cardiovascular pathology, congenital heart disease. Let's continue with right-to-left shunts, which are a major group of congenital heart diseases. Right-to-left shunts, early cyanosis. Right-to-left shunts cause early cyanosis, sometimes called blue babies. They are often diagnosed prenatally or become evident immediately after birth. Most of these conditions usually require urgent surgical treatment and sometimes require maintenance of a patent ductus arteriosus, or PDA, using prostaglandin therapy. The 5 T's of right-to-left shunts. You can remember them with the 5 T's. 1. Truncus arteriosus, 1 vessel. 2. Transposition of the great arteries, 2 switched vessels. 3. Tricuspid atresia, 3 as in tri. 4. Tetralogy of Fallot, 4 or tetra. 5. Total anomalous pulmonary venous return, TAPVR, which is 5 letters in the name. Persistent Truncus arteriosus. In this condition, the Truncus arteriosus fails to divide into the pulmonary trunk and the aorta due to failure of aorticopulmonary septum formation. Most patients with Truncus arteriosus also have an accompanying ventricular septal defect, or VSD. Detransposition of the great arteries. Here, the aorta leaves the right ventricle, which lies anterior, and the pulmonary trunk leaves the left ventricle, which lies posterior. This causes a complete separation of systemic and pulmonary circulations. This condition is not compatible with life unless a shunt is present to allow mixing of blood. Examples of shunts include a VSD, a PDA, or a patent foramen ovale. The cause is a failure of the aorticopulmonary septum to spiral. On chest X-ray, the narrow superior mediastinum creates the classic egg on a string appearance. Without surgical intervention, most infants die within the first few months of life. Tricuspid atresia. This condition is characterized by absence of the tricuspid valve and a hypoplastic right ventricle. For viability, the patient requires both an atrial septal defect and either a ventricular septal defect or a patent ductus arteriosus. On ECG, there is hypertrophy of the right atrium, which appears as tall P waves, and left ventricular hypertrophy, which shows as left axis deviation. Tetralogy of Fallot. Tetralogy of Fallot is caused by anterosuperior displacement of the infundibular septum. It is the most common cause of early childhood cyanosis. There are 4 key features remembered by the mnemonic proof. Pulmonary infundibular stenosis, which is the most important determinant for prognosis. Right ventricular hypertrophy, producing a boot-shaped heart on chest X-ray. Overriding aorta, which straddles the ventricular septal defect and receives blood from both ventricles. And the ventricular septal defect itself. Because of the pulmonary stenosis, blood is forced to flow right to left across the VSD. This causes right ventricular hypertrophy and produces TET spells. TET spells are episodes of cyanosis, often triggered by crying, fever, or exercise, which worsen right ventricular outflow obstruction. Squatting increases systemic vascular resistance, which reduces the right-left shunt and improves cyanosis. Tetralogy of Fallot is also associated with 22q11 syndromes. Total anomalous pulmonary venous return, TAPR. In TPVR, the pulmonary veins drain into the right heart circulation, such as the superior vena cava or the coronary sinus, instead of the left atrium. This condition is usually associated with an atrial septal defect and sometimes with a PDA to allow right-left shunting and maintain cardiac output. Ebstein anomaly. Ebstein anomaly involves downward displacement of the tricuspid valve leaflets into the right ventricle. This artificially atrializes the ventricle. It is associated with tricuspid regurgitation, accessory conduction pathways, and right-sided heart failure. Ebstein anomaly is rare, but it can be caused by lithium exposure in utero.